Welcome to Workplace Safety and Prescribed Medications for Patients with Chronic Pain. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners, Pain BC, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all of these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Paul Farnan. Dr. Farnan has worked in the field of addiction medicine and occupational medicine for more than 25 years. As well as being a member of the Occupational and Environmental Medical Association of Canada, he is board certified in addiction medicine and family practice. He is a clinical associate professor in the Department of Family Practice at the University of British Columbia. His consulting with employers and unions has involved developing and delivering programs to assist employees whose work is impacted by addiction and other substance use challenges. He has a particular interest in the interface between workplace safety and impairment at work as a result of prescription medication use, illicit drug use, and marijuana use. And now I'll hand it over to Dr. Farnan.
Thank you, Angie. Can you see my screen?
Yes, we can.
Perfect. Thank you. Thanks for the invitation to do this today. It's taken us some time to get it coordinated. As you say, my professional practice is based in Vancouver. Webinars I find difficult because I don't really know who's out there or what disciplines they're in as I try to prepare this presentation. But my work is mainly at the interface of occupational medicine, addiction medicine. I'm not a pain specialist and I don't have a pain practice. Over the years, while I might have been consulted by employers for a lot of what would be considered standard addiction problems, the drug and alcohol issues, increasingly, as we've seen with increased prescribing of medications, I would receive more referrals for individuals who are struggling perhaps with medications that they're on and looking for some advice or help with regards to return to work and safe return to work. So that was the way I approached this. I have no particular disclosures to make, particularly I have no pharmaceutical or medical product affiliations. I am in receipt of a grant with some others studying we're doing a systematic review of the effect of cannabis in safety sensitive workers. I have some honoraria from a variety of places, none for today and no perceived bias, I think, to mitigate. So when we spoke about this a long time ago, I reflected back to my notes and we spoke about understanding the perspective and the concerns. Oh, did I upset the screen there? Upset the perspective and concerns of different stakeholders regarding safe workplace and medication-related impairments, because there are a lot of potential stakeholders involved in such a process. And I thought reflect on some of the main groups that appear to be used regularly in the treatment of patients with chronic pain and how they may impact safety or impairment at work. And then hopefully that you would be able to return to your workplace in the many different disciplines that I think you're in and have maybe not lots of answers, but certainly some questions to reflect on with regards to how to best help people in your organization. So over the years, doing a lot of work in occupational medicine, I'm very aware that work is good for us, and I'm very aware that there are benefits that we get from work, financial, social, discipline, opportunity, and I'm also aware that there are disadvantages to being unemployed or not at work, social and health inequalities, mental health, physical health issues. So work is important. If you ask physicians if they have any role in assisting patients in returning to work, there is no real training in occupational medicine in medical schools and most residencies, and most physicians would not be familiar with the concept of stay at work or return to work, which I suspect most of this group are. That proactive kind of comprehensive program to try to help employees with work-related illnesses or injuries return to work. But in fact, the Canadian Medical Association developed a paper a long time ago and updated it in 2013, and it's specifically called The Physician's Role in Helping Patients Return to Work After an Illness or Injury. And this clutters the slide a little bit, but it did quote a paragraph that I think is probably relevant, and perhaps for some of you when you're dealing with physicians, and that is the treating physician's role is to diagnose and treat the illness or injury. And I think most physicians are very comfortable. That's where they see their niche. To advise and support the patient, I think they agree with that, and they try to do that. To provide and communicate appropriate information to the patient and to the employer, they're not very familiar with, and often they're either very reluctant to give any information that would be helpful, that's appropriate information, or they feel they need to give all kinds of information and they give way too much information to the employer. Also, it's recommended that physicians would work closely with other involved healthcare professionals to facilitate the patient's safe and timely return to the most productive employment possible. And I'm sure there are other health professionals probably on this line who have torn their hair out at times trying to deal with physicians who don't seem to be good team players. We were never trained that way. It's improving, but physicians do have a responsibility in this regard. We live in an interesting time, I think. We have our Canadian workforce getting older, not retiring as quickly as it used to. And therefore, I think I've seen in my years in practice a greater prominence in certain conditions. And I just anecdotally picked these 5. This is no study. This was just from my reflection. What are the things that I commonly see people getting stuck on not being able to get back to work? And you can see I highlighted that 3 of them involve pain. And so it's interesting that we have a workforce getting older, and pain is certainly an issue. And of course, the primary goal of caring for patients with chronic pain is not just the reduction of the pain experience, but improvement of function. And this is the same for diabetes. It's not just about getting the blood sugars looking good. It's how do you help ensure that the function is improved. Same with depression. It's not just some remission of symptoms, but how do you help normalize and help that person return to work. WorkSafe BC, I'm in British Columbia, have some guidelines. It's interesting that there are no real federal guidelines about impairment at work. It's usually left to the provinces. And the guidelines in British Columbia state that a person should not enter or remain at any workplace while that person's ability to work is affected by alcohol, a drug, or other substance so as to endanger the person or anyone else. And of course, it extends then is that the employer has a responsibility and must not knowingly permit a person to remain at any workplace while the person's ability to work is affected by alcohol, a drug, or other substance so as to endanger the person or anyone else. And I'll go back to that point that many, many years ago, I think because of my addiction training and expertise, and it still happens that people will be referred to my office because there's a concern about an evolving substance use disorder. But increasingly over the last several years, employers are really concerned about an employee who is being prescribed a whole lot of different medications, and they're concerned about their ability to safely return to work. And that's not necessarily addiction per se. I'm sure all of this group would be familiar with the concept of safety-sensitive work. Not all physicians are. And a safety-sensitive position is one that, if not performed in a safe manner, could cause direct and significant damage to property or injury to the employee, most importantly, others around them, the public and the immediate environment. So we emphasize the importance to physicians that we interact with about the need to avoid cognitive psychomotor impairment, especially with regards to any medications that might be prescribed. But to be honest, a lot of physicians are not familiar with this concept, and work is work for them. Whereas in my office, probably most people refer to my office actually are working in a safety-sensitive position. So we're at this situation, of course, of trying to balance pain treatment options we have probably overdone it, on the medications in a way over many years, and there are some good non-pharmacological approaches that we don't seem to be able to access as much, or are not as funded as well, and that can be problematic. So today my focus was really to hone in on the kind of medication side and talk a little bit about that. So the impairing effects as part of treatment for persons with chronic non-cancer pain. And of course, there are some medications used or prescribed or used over the counter that don't have much of a concerning impairing effect, and there are others that are more significant. So what I tried to think in my head was, what are the main groups of medications, excuse me, that people come to my office with concerns about, and there's the painkillers, my painkillers doctor, and of course there is no painkiller, but generally we're talking there about opioids. Other opioids, I just thought I'll mention a little bit if I have time, is methadone and buprenorphine, which is the active opiate in Suboxone, because we're going to see more use of that. Sleeping pills, sedatives, still prescribed a lot, although we know that it's quite dangerous to co-prescribe opioids and sedatives. This concept of medical marijuana, I would emphasize that I don't know what that means, because there is no medical marijuana. There's marijuana being used for medical purposes, and that's a whole other day workshop. But I tried to put together a few slides of what I think might be important. I will deliberately try to avoid getting into these whole opioid overdose crisis, epidemic, fentanyl. But we'll try to reference it a little bit, because it's a reality in our community. So this graph, you might not be able to see the x-axis there. It's from 1980 to 2015, and all of us know that in the mid-90s, the use of opioids in the Western world, the prescription of opioids, just increased quite dramatically. But in the last couple of years, that's kind of flattened off a little bit. Canada, I think, is still the second highest opioid consumption amongst developed countries, and that, of course, is significant. Doctors get blamed a lot of causing this problem, and certainly, we're part of it. And for those of you who don't know, the key message, very carefully delivered to physicians in the 90s by the pharmaceutical industry, was that opioids were extremely safe and effective for treatment of chronic pain, that there was really no risk of addiction, and repeatedly it was quoted that less than 1% of possibility of becoming addicted to opiates, that it could easily be discontinued, which we know, and if any of you have ever been on opiates, you know that this is not true. And then because of opiophobia, physicians are allowing patients with pain to suffer needlessly. So this message was fairly strongly delivered, and the profession responded. And of course, we saw a great escalation, as we noted in that graph. As time went by, things didn't always seem to be going as well as anticipated. And what was particularly noted by some researchers was that there seemed to be a risk of accidental overdose, adverse outcomes, or even death. And this this slide, it shows 4 studies. And again, on the x-axis, it's trying to show if you have this dose of milligram morphine equivalent per day, and then on the y-axis is the risk ratio of an adverse event or an opioid overdose happening. It appears fairly clear that as the dose goes up, the risk of accidental overdose also goes up. And in the blue, if you can see the blue, the Dunn study in 2010, their findings were that there was a ninefold increased chance of accidental or inadvertent opiate overdose if you were up around the 100 milligrams per day or more. And this is interesting because we had no idea of this at the start. Indeed, the Canadian guidelines from 2010 suggested that perhaps 200 milligram of morphine equivalent per day was a watchful dose, and above that, just be careful, but there probably wouldn't be much problems if you went up to 200 milligrams. And of course, now we've had a whole series of guidelines and changes, and we had the CDC in the United States in 2016 come up with their guidelines. In my province, we had our regulator, our College of Physicians and Surgeons of BC, come out with guidelines with regards to opioid prescribing, and the emphasis, I guess, was not just on the risk of overdose or accidental overdose, but that the risk for addiction was much greater than initially thought. And amongst individuals with a new episode of chronic lung cancer pain, there's actually a strong risk factor for developing opioid use disorders. And this bottom half of this slide is really meant to note that it's probably the duration as well as the dose that's important, and we only used to focus on the dose. So long-term prescription opioid use, more than what's considered more than 90 days, seems to be associated with an increased risk of developing an opioid abuse or dependence diagnosis versus no opioid treatment. And the odds ratio, OR 15, the odds ratio for low dose use is 15. The odds ratio for moderate dose 36 to 120 milligram equivalent of morphine per day up to 29. But the odds ratio, if in dosing above 120 milligrams per day, right up there at 122 times the risk. So significant information we weren't always aware of. And last year we had our Canadian national guidelines for opioid therapy and chronic lung cancer pain management. And they're quite similar to the CDC and to our college here and other provincial regulators. And basically that said, for patients beginning opioid therapy, we recommend restricting to less than 90 milligrams of morphine equivalents per day. And we suggest restricting the maximum prescribed dose to less than 50 milligrams morphine equivalent per day. And for patients already receiving high dose opioid therapy, that is now considered to be greater than 90 milligram equivalents of morphine equivalents per day, should be encouraged to embark on a gradual dose taper, and multidisciplinary support should be offered where available to those who experience challenges. Now, in the real world, I can only tell you anecdotally, because a lot of physicians contact me looking for advice. I think physicians are trying to prescribe closer to the guidelines if they initiate opioid prescribing, long-term opioid prescribing. But many have inherited or have these legacy patients who have very high doses or now considered very high doses of opiates. And it's been suggested that they should just gradually taper the dose, which sounds such an easy thing on this slide, but for any of you who've been involved in that process, it's extremely difficult to do in a time when folks often don't have a regular family physician. They're going to walk-in clinics and so forth, and implying that of course this is a multidisciplinary problem and it needs multidisciplinary support, but that's rarely available. So it's a very challenging time, I think, for all, including physicians. Put on top of that, that the reality that as the research comes through, it starts to become apparent that opiates were not the panacea that we thought they were. And in fact, it appears that the risk can outweigh the benefits. This is a large study of Roger Chow in the Annals of Internal Medicine, February 2015, the effectiveness and risk of long-term opioid therapy for chronic pain. Systematic review of National Institutes of Health Pathways to Prevention workshop. And their conclusion was evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. Evidence supports a dose-dependent risk for serious harms. And actually just yesterday, I think I have a slide here. So just published yesterday was this large randomized control trial, the SPACE randomized control trial, looking at the effect of opioid versus non-opioid medications on pain-related function in patients with chronic back pain or hip or knee osteoarthritis pain. And their conclusions were that treatment with opioids was not superior to treatment with non-opioid medications for improving pain-related function over 12 months. Results do not support initiation of opioid therapy for moderate to severe chronic back pain or hip or knee or arthritis pain. So these studies are all, very interesting at the academic level, but it's very difficult for patients with chronic pain, and especially patients who've been on opiates for quite a long time, because as they try to taper, they're going to experience quite a bit of withdrawal from the taper, as well as whatever underlying pain situation they had. So really, we're in this situation where the pendulum swings. In the 1990s, chronic pain is a disease. It warrants aggressive and humane treatment. And now we keep hearing this word opioid epidemic. And I put that in quotations because maybe it's a bit of a crisis, but I think epidemic is the wrong word. It's not contagious and infectious, and I think there's a bit of a drama to that. But in any event, the opioid crisis, epidemic, is considered to be a plague that must be eradicated at all costs. I'm assuming, so in the 90s, we were at the extreme of leniency and prescribing opiates, and now we are probably come to our, the most conservative prescribing with regards to recommendations. But still in all, we still have a significant amount of opioids out there, and it still is very relevant to people who are prescribed opiates, and still very relevant for people who are returning to work to safety sensitive positions, which I'll talk about in just a moment. To give you, I don't know who's on this conference, but to give you some idea of how things are changing in this country, the Ontario Drug Policy Research Network last year suggested that they're noting the overall volume of opioids dispensed fell by 18% between January 2015 and March 2017 in that province, driven primarily by a reduction in the amount of long-acting, slow-release formulations. And the number of people prescribed an opioid, however, remained relatively constant over the last 5 years. 1 in 7 Ontarians treated with potentially addictive medications last year, and nearly 40% of long-acting opioid prescriptions dispensed to people already using the drug for pain had daily doses that surpassed the recommended threshold under these newer 2017 Canadian prescription guidelines for opioid use in chronic non-cancer pain. So still a lot of opioids being prescribed, and one of the main concerns for me is the negative impairing effect which opioids are proven to have on cognitive and psychomotor functioning, on cognitive and thinking and decision making, and on psychomotor function, which is reaction times and motor skills and so forth. And this isn't talked about that much, and in fact, the whole issue of opioid use and prescribing in the workforce isn't talked about very much. But a group that does have a lens or is interested in this, of course, is insurance carriers. I don't know if there are any people on this call, but here's a note from a large study done as a Lockton Company's report. It said claimants on long-term opiates more than 90 days are not typically going back to work. They've become tolerant or even dependent on the drugs and suffer multitudes of associated illnesses and debilitating side effects secondary to the drugs use. And this Hopkins Accident Research Fund study said that found that workers prescribed even one opioid had average total claims costs 4 to 8 times greater than claimants with similar claims who didn't get opiates. So the point I'm making is very few people have really studied or looked at the issues with regards to prescribing for workers, or the effect on workers, or and so forth. And of course, that's what I'm particularly interested in. I bring this study here I found interesting. It's over 10 years, and it's the characteristics of initiation prescription episodes and likelihood of long-term opioid use. Physicians, I think, are reading more of this literature, and what it's saying is that it's suggesting that there should be an awareness amongst prescribers, pharmacists, a person managing pharmacy benefits, that authorization of a second opioid prescription doubles the risk for opioid use 1 year later. And that if there was that awareness that it might deter overprescribing of opiates. There is, again, growing literature, wasn't there in the 90s, but growing literature of emergency room physicians, dentists, some orthopedic surgeons, sometimes wanting to try to help a patient with pain and trying to ensure that they're not going to come back to the emergency room unnecessarily or come back after their wisdom teeth removal. So getting relatively large amounts, of opioids for a small procedure and maybe getting that prescription repeated and then finding that they're staying on them longer term. So knowledge that the risks of chronic opioid increase with each additional day supplied might help clinicians evaluate their initial opioid prescribing decisions and potentially reduce the risk for long-term opioid use. Discussions with patients about the long-term use of opioids to manage pain should occur clearly in the opioid prescribing process. And absolutely that is within the guidelines now, how important it is to really explain to patients, you got to look at the risks, you got to look at the benefits, and you got to try to figure out, is this a right choice for you? Can we do this as a trial? Because it may be that this is not a good family drug for you to be on. Very infrequently, I find physicians will say to somebody, so please explain to me what you do in the workplace and tell me the exact nature of your work so that I understand whether it's safety sensitive or not. And again, just little coverage of, I find little coverage of occupational health, safety, workplace issues. Now, interestingly, in our crisis in our province, where Dr. Kendall declared a public health emergency, we have a lot of public health physicians, and they see the world differently to me, as most specialties have a different lens, and they're very much focused on trying to help. In fact, it has been driven mainly by many of the unfortunate, disenfranchised, street entrenched people in the downtown east side of Vancouver, and that has driven a lot of the response to how do we deal with this opioid crisis. Interestingly, one of the Fraser Health chief medical officer, looking at their data, it suddenly strikes them, men between 19 and 59 are relevant. And in fact, this isn't just this core group in the downtown east side, but this affects many people. And it's a full slide again, but just to quote her statement, she said, men between ages 19 and 59 are disproportionately affected by a hidden epidemic that's shrouded in secrecy amongst those too ashamed to get help. She said men who are injured on the job may be ensnared into dependence on illicit substances after being prescribed pain medication. And Fraser Health is planning a workshop next week for employees, employers, and trades representatives to explore interventions that could help men who don't reach out when they're struggling with substance use issues. So it was one of the few places I saw where people are starting to say, oh, you know what, this could be relevant for the work, for people who are at work too. And again, not wanting to focus on our the reality that organized crime are very good business people, and they made sure they brought fentanyl into the system and put it in pills and sold it and have it in everything from heroin to crystal meth to whatever, and that we have these huge numbers of people who are overdosing. So the response again from many of the folks in this province to this crisis has been to develop a set of what they call managing opioid use disorders, and they have been promoting this across the country. And in fact, on this slide, you might see there on March the 5th, so just a couple of days ago, the Management of Opioid Use Disorders and National Clinical Practice Guideline. If any of you are interested, you might want to take a look at that. And that's been developed by some physicians across Canada. But again, I'm not aware there's any occupational medicine physician on the panel. It's very much about saving lives at what can sometimes appear to be an advanced stage of addiction, almost a palliative approach, and the focus is on trying to give people opioids almost as a substitution therapy, methadone assisted or medication assisted treatment. And the drugs being emphasized will be Suboxone, which contains buprenorphine, i.e. an opiate, methadone, an opiate, providing people with slow release oral morphine if they want it. And although not considered in this guidelines, it's been suggested that some folks their disease may be advanced enough that they will require injectables, or for those of you who live in BC, you're aware we have injection heroin and hydromorphone sites downtown. All to say, really, that this is all, I think, relevant for us across Canada, that we have this perceived, crisis epidemic, for whatever it wants to be called, for prescribed opioids. And now we have a solution that is going to include more opioids. And while that is going to be really important to save some lives, it's going to be something that's important for those of us who work in workplace type settings. So just to emphasize about the issues of impairment associated with opioids, lots of evidence of cognitive impairment with opioid use, psychomotor impairment. For some reason, although the coroners tell us repeatedly they should not be prescribed, co-prescribed opioids with benzodiazepines, the Valiums and the Xanaxes of the world, repeatedly people are prescribed both of those. They have a cumulative sedative effect, and many of the overdose victims are found to have both opioids and sedatives in their system. Outside of co-prescribing, just advising patients, you shouldn't really use alcohol or cannabis or any other sedating drugs when you're taking opioids, because you put increased risk of overdose. And unfortunately, many of these patients have many challenges. As well as they're on opiates, they have ongoing pain, they have ongoing medical issues, they have psychiatric issues that may involve use of a psychiatric medication. They have sleep disordered breathing. Many get sleep apnea, which puts them at increased risk. So in the United States, of course, they looked at this a few years ago, and ACOM, the American College of Occupational Environmental Medicine, put together practice guidelines, and there's some pretty heavy hitters on that list, on that panel. Dr. Charles Ells, a Canadian, is in there, on opioids and safety-sensitive work, and they said that opioids and safety-sensitive work can be a real problem mix. And the American, so their statement was that acute or chronic opioid use is not recommended for patients who perform safety-sensitive jobs, and these jobs might include operating motor vehicles, other modes of transportation, forklift driving, overhead crane operation, heavy equipment operation, etc. Again, bottom line, in the United States, the summary was, the quality evidence shows consistently that there's increased risk of vehicle crashes, and we use the activities involved in driving as a surrogate to check for other safety-sensitive work. So what you do to drive with the cognitive skills and psychomotor skills often equate to other safety-sensitive work. So we look at crash data, and quality evidence consistently demonstrates increased risk, and it's recommended as a surrogate for other safety-sensitive work tests. So when we speak to physicians, we realize, yes, there's tolerance, withdrawal, side effects that can happen with chronic long-term opioid medications. There is that challenge of opioid-induced hyperalgesia, that paradoxical worsening of pain that happens with opioids, where the pain seems to get worse and we chase the pain with more opiates. There's an increased risk of abuse and dependence, well documented, and there's an increased risk chance of incidental overdose and death. I think most physicians know that. What most physicians don't know is there's a decreased chance of ultimately returning to work if you're on long-term opioids. That's what the literature shows. And there's an increased risk of impairment and safety risks at work. So I want to quickly move on to just to try to summarize. And I had a really hard time trying to do these few slides because I've got hundreds of slides on this subject. But how often patients will say, I just smoke one joint a day, doc, it cures everything, it's all natural. And of course, a lot depends on what size the joint is or what people are smoking. So oversimplification, cannabis is the plant. Marijuana is dried cannabis. There are several strains. The most common is sativa and indica. In the plant, there are 500 chemicals at least, probably more. We haven't got good research on that. And within those chemicals, there's a category of phytocannabinoids, and the cannabinoids are very relevant. The most well-known is the delta-9 THC, but there are others, probably up to 100 others, and it's not well studied. In our brain, we have an endocannabinoid system with receptors on it, and ironically or interestingly, we have a couple of endogenous cannabinoids, or cannabinoids that are inside of us that act, and then we have these exogenous cannabinoids that are in the marijuana plant. And we actually have some prescription cannabinoids that are prepared by pharmaceuticals industries and quality controlled and so forth. There are varying ratios of THC to CBD, for example, in various products, and often we really have no idea what's in the product. But many patients come in and say, I want to use this. In Canada, we have had access to cannabis for medical purposes for many years. And basically what happened was the government decided here that dried marijuana is not an approved drug or medicine. It does not endorse the use of marijuana for medical reasons, but the courts have required reasonable access to a legal source of marijuana when authorized by a physician. And those of you who watch this know that authorized is not prescribed. This product has no DIN number in Canada. It's no drug identification number. It's not recognized as having strong evidence for many of the conditions that people want to use it for. So it's not formally prescribed. A prescription isn't written, but somebody may come to your workplace with what looks like a prescription, and it's an authorization by a physician that to use marijuana. The Canadian Medical Association is concerned that there's little good research about evidence to support its use, and there's absence of a regulatory oversight and approval. This is just showing the number of people registered for medical marijuana in Canada up to December 2016, and basically 130,000 Canadians had signed up with cannabis producers by December 2016. That was a 32% jump from September 2016 and 1,544% increase from the 7,900 granted access to medical cannabis in mid 2014. Now, in my job, it's sometimes difficult, and I know some occupational health nurses and some HR people, are very interested in this, and they become well informed, and they want to have a discussion with an individual about the use of marijuana or why they're using it, and if it seems like a good idea. And I'll just show you a couple of, there are always studies, small studies, and usually at the end of the studies it says there may be some benefit from this for this condition. We recommend, larger studies. That's often what the recommendation is. But many of the researchers who do really good research and put together systematic reviews or gather a whole lot of studies and try to get some summary, such as this one said the effects of cannabis amongst adults with chronic pain and an overview of general harms. That was 27 chronic pain trials, and basically the summary there was there's limited evidence suggests that cannabis may alleviate neuropathic pain in some patients, but insufficient evidence exists for other types of chronic pain. Among general populations, limited evidence suggests that cannabis is associated with an increased risk of adverse mental health effects. So there seems to be some evidence that cannabis could be beneficial for some types of chronic pain. And in fact, many of these studies include prescribed cannabinoids, pharmaceutical grade cannabinoids, as opposed to something that's bought down the street. What about PTSD? We use it a lot. We fund it a lot, and this large study in August 2017 suggests that the evidence is insufficient to draw a conclusion about the benefits and harms of plant-based cannabis preparations in patients with PTSD, and several ongoing studies may soon provide important results. Another systematic review and meta-analysis, big study by Whiting, and what did that say? There was moderate quality evidence to support the use of cannabinoids for the treatment of chronic pain and spasticity, but low quality evidence suggesting cannabinoids were associated with improvement in nausea, vomiting due to chemotherapy, weight gain in HIV infection, sleep disorders, and Tourette's. Cannabinoids were associated with increased risk of short-term adverse events. So, you try to be the scientist, and I find myself, trying to present and keep up to date and present the data to people in my office, and some really don't want to hear it and are quite mad, and others are, oh wow, I didn't know that. Okay, I'm happy to try to listen to you about that. Dr. Nora Volkow, probably one of the major researchers in addiction and substance use in the world, did a really good summary paper on the adverse effects of marijuana use. And in the short term, particularly impaired memory, making it difficult to learn, impaired motor coordination, impaired driving, increased risk of injury, altered judgment, paranoia, and psychosis in high doses. And of course, many of the producers are trying to up the potency of the THC content of the product and lower potentially protective levels of CBD or other cannabinoids. But in any event, what she showed, especially in the short term, is that there are significant impairing effects associated with marijuana. Now, I would add that there are many physicians phone me or patients come in and say, well, opiates are really bad and I'm getting all this grief from the college and everywhere else. So cannabis is a benign herb. Let's just put everyone on that or support everyone. And certainly there is this emerging advocacy movement for greater use of marijuana. But as I say to you, I'm just a scientist guy who wants to look at the trials, and the trials evaluating marijuana for chronic pain have typically used synthetic or prescription cannabinoids rather than the mother plant, smoking the mother plant. They show modest benefits. The studies have been quite limited, and it seems to be that they are better for neuropathic pain than for musculoskeletal pain. And this article said that, clinicians must be careful in replacing the opioid epidemic with the marijuana epidemic. This is just a quote, and as I said, I'm not particularly keen on that word epidemic. So we're going to have we're going to have the second stream. We're going to have legalization of marijuana in our country next year. I read in detail the works of the task force. I felt they were light on the effect on youth, mental health, impaired driving, and workplace safety. But there is an absolute drive in Canada to legalize, regulate, and most importantly, tax this product. So it's coming at us, and there will probably be an increased use in the workplace. Just to remind you, how does cannabis cause impairment? Absolute evidence for psychomotor impairment, for cognitive impairment. The potency, unfortunately, people have no idea usually of the potency, how they smoke it, whether they use edibles. There's no quality control. When they look at what's sold in shops, it's rarely, the potency rarely matches up with what's tested in the lab. And there is a genuine risk of addiction. People think you can't get addicted to marijuana, but there's a 9% risk of people who use marijuana regularly developing true addiction. Now, it doesn't look like heroin addiction or severe alcoholism. It looks different, so it doesn't attract as much attention, but it exists. Again, we use driving as a facsimile for safety sensitive duties, as I said before. So when you look at marijuana, particularly interesting is that there's a definite increased risk in motor vehicle crashes for sure. The risk can be as high as double after recent use. Many people can kind of titrate the effect of smoking a joint and knowing they're high and then thinking, oh, I'm probably okay to drive home. One of the problems, especially with edibles, is the onset is slower. It doesn't reach the same peak, but it lasts much longer. So many problems associated with edibles. Drivers who use marijuana are 3 to 7 times more culpable than those that did not use marijuana in a well-known study by Rainmakers. And compounding factors it's really difficult to figure out the amount consumed. The potency depends on the route, how long you use for, when you first started, the tolerance you might have developed, impairment in withdrawal or intoxication. And acute use is clearly impairing, and this is very relevant for driving and for safety sensitive work. Some studies have suggested that given the potency of marijuana in the 60s was maybe 3% THC, and it's probably up around 12%, or it's supposed to be in many of the producers. But in BC, it can be as high as 20, 30%. Hash oil and shatter, for example, is 85 to 90% THC. I mean, it's hugely potent. So we don't know a dose, and we don't know a safe limit. So it's really impossible to be recommending, especially smoked marijuana. When people ask me about from the workplace, ask me about, the guy has a prescription for medical use, or this lady has a prescription for medical use, you have to back up and say, well, you got an authorization, perhaps from a physician who doesn't know the safety sensitive nature of the individual's job, so you may have to explore that. But what I try to emphasize is that there are some cannabinoids which appear to have the potential for use to treat certain medical conditions. And we need to do more research, and there could be very exciting times ahead, but we're not there yet. But there certainly is no simple strain of marijuana or medical marijuana. And, you know, telling people to smoke the mother plant, we know that opium contains opiates, and we've been able to distill that and get morphine and get opiates to use. You know, for chronic pain, we don't tell people go smoke a bunch of opium. So telling people to go smoke marijuana for pain is probably doesn't match up scientifically. What is a dose? We don't know. As I said, an authorization is not a prescription. But even if somebody has approved usages, some workplaces may have to exclude an individual from working in a safety sensitive position. That may be the reality. And I generally advise workplaces to think of cannabis or marijuana like other psychoactive, potentially impairing drugs. What do you do if someone comes to you and tells you they're on opioids or benzodiazepines and they want to return to safety sensitive work? For those who work in occupational health and safety, I know their priority is safety, safety, safety. And for physicians, I try to say to them, first, do no harm. Medical, even if you consider that this is, you know, you believe it's got some medical benefit, it doesn't mean it's necessarily safe. Just because it's made legal doesn't mean it's safe, which a lot of young people are thinking, oh, once it's legal, it must be safe in the future. Cannabis is not necessarily benign, and neither opioid medications nor cannabinoids for medical purposes is the answer to chronic non-malignant pain, and both are potentially impairing. And you know, I advise physicians, many who are younger than me, to remember what happened with opioids, where there was a strong promotion and all kinds of, you know, talks and subsidized education events by drug companies. And a lot of this is kind of happening with producers now, and going to physicians' office and explaining the great benefits of cannabis. But nothing gets mentioned about safety in the workplace. So again, our colleagues south of the border, ACOM, Marijuana in the Workplace, they produce some guidelines. So it's actually ACOM and the American College of Occupational, the American Association of Occupational Health Nurses produced a joint statement on this issue, marijuana in the workplace. And the Joint Task Force recommended that marijuana use is closely monitored for all employees in safety-sensitive positions, whether they're covered by their federal drug testing or not. And the best practice would support employers prohibiting marijuana use at work. Makes sense. And employers in compliance with applicable state laws may choose to simply prohibit their employees from working while using or impaired by marijuana. So a lot ahead for us in Canada. Not clear. We can't even get it clear about impairment for driving and what we're going to do about that. And impairment in the workplace is going to be an interesting challenge. And this paper by Charles Els and Sebastian Staub is a good paper. It's in the Canadian Journal of Addiction Medicine. It might be about a year ago, I forget exactly, but a good paper, and I think it reflects sensibly on a lot of these issues. And their summary was, occasional or ongoing marijuana use, legal or illegal, is not recommended for persons who perform safety-sensitive jobs. The problem is, and Health Canada notes this, is that the impairing effect can last up to and for more than 24 hours. And that's the problem. When physicians ask me about other medications, in fact, physicians rarely ask about other medications because they forget that we use other medications to treat or as an adjunct for pain, antidepressants, quetiapine, olanzapine, mirtazapine, all of these medications here. If you just go to the pill box and you look on the side, what it says is drowsiness, clumsiness, blurred vision, confusion, memory problems, balance difficulties, difficulty concentrating. So again, speaking with my colleagues, I'm trying to speak about the issue of side effects and the risks associated with medication use, and trying to emphasize the risk of what we call polypharmacy. So the side effects are cumulative. If we add different categories of drugs, the side effects become greater than the individual effects. And this is really important for people returning to work. So in conclusion, I think work is very important. Workplace safety is very important. We have many generations in the workplace. We're likely going to be dealing with increased disability, including pain, and we need to think about that. And although there's good evidence that a multidisciplinary approach to the treatment of pain, which might involve non-pharmacological as well as pharmacological approaches, is the gold standard, the reality is it's not easily available, and I think we're going to still see quite a reliance on prescription medications. over the years, even though we're in this phase of what some people are calling de-prescribing when it comes to traditional opioids. But remember, we're also in a phase of people, especially some public health docs and addiction docs who don't do any occupational medical work, looking at trying to address this opioid crisis. And this is going to involve further or more prescriptions, probably of methadone, buprenorphine, slow-release oral morphine, injectables as part of the response to this crisis. However, we must remember that opioid or overdose deaths are not confined to those unfortunate individuals who are street entrenched and in the downtown east side. Opioid and fentanyl overdoses occur at every level of society. So I think we will need collectively to make sure that we're considering all of that as workers might come to their occupational health nurse, the disability manager, or their HR person seeking some advice that they're started on these medications, and what do you think I should do? As I said, the impairment concern expands past the side effect risk of just one drug. And, I believe these issues are really important. I hope that I know that I couldn't have addressed things specifically to many people here today, but I hope that in some way that I've presented something that might be of some assistance in the field you're in. Yes, I focused on an occupational medicine lens, and you are a diverse group, and I wouldn't assume to have answered perhaps a lot of your individual questions, but I hope that I might have given you some food for thought to consider in your unique workplace or your role as you return to the responsibilities you have with your organization. And I think with that, I will stop, Angie, if that's okay, and I will attempt to answer any questions if there are.
Great, thank you. To our audience, if you have any questions at this time, please enter them into the question and answer box on the GoToWebinar panel, and we'll ask them out loud. A few questions that came in. I'm going to combine these because there were several. When treating chronic pain patients with non-opioid treatments, what have you found or through your research that generally works? What is your opinion on mindfulness meditation as one of the alternatives to opioids?
Yeah, that's a really great question. And I wish I had a very carefully constructed answer. But what I would say is, there's a few things first of all, I believe we were kind of conned, and I, like others, fell into this trap of how do we treat chronic pain, and forgot for a while we don't treat chronic pain, we treat patients with chronic pain, and every patient is different. And some go through this kind of central sensitization that everything is amplified for them. The pain is really difficult, and if we just focus on opioids, that appears to be the only solution. So we just keep going down that road. But I think in the other options, there's lots of good evidence that cognitive behavioral therapy, including mindfulness, exercise, and mentoring and training in pain self-management are good options. Now, I say that quickly here. Patients, I find, will be insulted and often terrified if that just rolls off the tongue as if it's some easy fix. But I think part of managing patients with chronic pain is a chronic good relationship. And unfortunately, so many people have no family physicians, or if there are specialist pain clinics, you wait forever to see people and you can't get back in. But when somebody can connect with a physician who knows and believes that these processes are of benefit. I mean, mindfulness is not so much, it's going to make the pain go away, but being in the moment and helping me not to catastrophize about the pain, because pain is quite terrifying. These kinds of skills are really important, but they don't come easy. They take, it's a mindful-based practice because you have to practice them, you have to keep doing them. They're not easy accessible. And, I've had arguments with insurance carriers and WorkSafe BC, and, why would you pay so much for prescription medications, and why wouldn't you pay more for some of these other modalities of care that we're identifying as being really beneficial? So, sorry, that's probably a bit of a long-winded answer, but I do believe that while there's no quick fix or easy fix or one thing, I think we are not engaging enough in the non-pharmacological approaches to the treatment of chronic pain that I think there's good evidence we should be doing.
Mm-hmm. Another question that came in, is there a concern for working in a safety-sensitive position when using marijuana, 1 to 3 joints per week, in order to sleep?
Right. So, again, I always start back at the beginning. There is no good medical evidence that smoking marijuana is a good treatment for insomnia. Smoking marijuana is using that as a delivery mechanism is actually dangerous, and there are many chemicals that are carcinogenic in smoked marijuana. There are many patients. It's interesting when you sit down and you talk to them about this. You say, look, there are other alternate, better recognized and more scientifically researched ways to help with sleep. They will often say, okay, well then I'll do that. There are others who really want to smoke marijuana, and you have no idea really what they're smoking, and you don't know if they're smoking 1 joint 3 times a week or 1 joint 10 times a week. And for those, you just have to try to do an individual assessment. You have to try to evaluate the safety sensitiveness of what they're doing. Given that, as I said to you, that the impairing effect potentially lasts 24 hours or more, then smoking the night before is a problem if you're going to do truly safety sensitive work the next day. Now, remember, it's a bit like opioids when we kind of get used to them. Or even alcohol, when you a couple of drinks and you see people say, no, I'm okay to drive. The impairing effect does impair our ability to judge. And this is what the research has shown. People say, no, I'm good now. And then they get in these simulators and driving and do all this stuff. And the impairment, it's subtle. They're not grossly, obviously intoxicated, falling around, but they are subtly impaired when it comes to, especially to driving. So I think that would have to be a serious discussion with, the occupational health nurse at the company or the occupational doc, or if it's not that big a company, with whoever has that kind of responsibility. And sometimes if the drug's been authorized by a physician for that, sometimes with the patient involvement, saying, look, I need to let your doctor know what what a tilt hoist operator does in a sawmill, or a spoutman in a pulp mill, or whatever, because physicians have no idea what the patients, they don't have a clue what the patients do. And sometimes when you work with them and give them that information, they can make a wiser decision with regards to safeability.
Mm-hmm. Another question, is marijuana considered less addictive than opioids?
The $1 million question. It probably is. Yeah. But having said that, there is an absolute well-defined cannabis dependence syndrome, but it doesn't look as bad, as I said, as heroin or alcohol. But it's compulsive use, difficulty stopping, negative consequences, often behavioral issues associated, moodiness and withdrawal and irritability. A lot of the things that your parents thought was a problem when you were a teenager, when you were maybe smoking a little weed, but no, I'm exaggerating there, but there are times when people become dependent on cannabis. I mean, it happens all the time. I had a woman in the office earlier this week, coincidentally, and she's coming back and going back to work. And she said, I had no idea. I just did not appreciate where this had gone. I just assumed I was self-medicating anxiety and insomnia. And we went over showed her the literature that high THC content or compounds are more likely to cause increased anxiety. And in fact, the recommendations are anyone with mental health diagnoses really should not be using marijuana. I think I've kind of wandered off the question. I'll stop there.
Thank you. So we did have a few questions that came in, but we'd like to end our presentation right at the top of the hour. So I'll take these aside and ask Dr. Farnan if he can answer them over email. But Dr. Farnan, is there anything you would like to add following your presentation?
No, it's as I say, it's difficult, knowing who's here or who's online. But for those of you who whether it's you're working with bargaining units or you're working with employers or whatever, I think the key thing is these are men and women often who have serious pain issues. They're desperately trying to get their life better and turned around, and we just need to be careful that we don't contribute in any way to compromising safety with adverse medication outcomes or events. And I think it's safety. That's the priority.